यहाँ टेबल लगानी पड़ेगी।
हेलो,
ये हिलेगी क्या?
हेलो।
हाँ,
टेबल को ले लो, ऊंची भी है तो अच्छा आएगा।
ये भी ठीक आ रहा है आई थिंक,
ठीक है
है ना?
लाइव हो गया।
ये वाला आना चाहिए
लिंक शेयर
पोडियम।
और लिंक शेयर कर इसका और
एक सेकंड
जी ने ग्रुप पे डाल दी।
हटियो, उसका एकदम साइड हो।
सुनो ये अच्छा ये जाएगी
मैम वो
तो ये दिखेगी
हम
कैसे?
लैपटॉप टर्न कर देंगे।
ये तुम्हारा उस पे नहीं ना वो कनेक्ट होगा
इस पे हम
ये दिस विल नॉट कम डायरेक्टली ना, वो जूम पे आता है वो।
इसलिए मैम कैमरास पे
मैम
दो
अगर
अलग
HDMI
अलग
से
हो
connect-
जाते हैं। हाँ,
दो
बेटा HDMI से
ऐसा
तो वो
कैमरा
मुश्किल
होता
से
है
चला है, मैक पे वही नहीं चल रहा था।
मैम स्पीकर तो ऐसे ही आ
सुनो
पाएंगे।
अगर हम HDMI इस पे कनेक्ट कर देंगे फिर उस पे नहीं चलेगा। चलो ठीक है,
इसका माइक्रोफोन
चलने
कर
दो।
दिया ना।
अभी मैम कुछ नहीं किया।
एक चीज कर सकते हैं, हमारे वाले कहाँ हैं? हमारे
हेलो
वालों को भी बुला लो। हमारे वाले
हेलो,
सामने
हेलो।
वालों को भी बुला लो यार। ये कह रहे इनके वाले भी फ्री है।
हेलो हेलो,
आजा आजा।
नहीं आ रहा
आपके फोन से नहीं गया। हाँ
हेलो
हेलो आ गया।
हेलो हेलो,
अभी मैंने से इंट्राविट्रेल
अच्छा
बंद कर दिया।
ठीक है मैं ट्राई करती
आ
हूँ।
रहा है? आवाज आ रही है? ठीक है, नाइस।
गूगल से ही आना है
12:30 का चल रहा है।
मतलब मैं टैब पे खोल रही हूँ ना ये वाले अकाउंट से इसलिए आ रहा है।
बस थोड़ा माइक्रोफोन में थोड़ा और लाउड करना पड़ेगा।
उनको बोल डायरेक्टली यहाँ से वो तो बंद हो गया।
लाउड
हाँ हाँ सिक्योर अभी का नहीं आया।
नहीं
कम आएगा।
1 घंटे 45 मिनट।
अच्छा
अंशिका वो लिंक यही है ना लिंक बेटा?
मैम
ये
एक बार
किस
देख
चीज
लो।
का यूट्यूब का है?
हाँ, एक
ये
बार
मैं
फिर से
इसमें
check कर लो।
Live
हाँ, एक बार
video.
खोल के देख लो कि चल रहा है।
नहीं ये खोल के देखो, मैं बीच में नहीं करती। मैम से लिया क्या रुक जा रहा है मैम आई तो इंट्रोडक्शन करेंगे इधर भी है
हाँ जहाँ दिखाया वहाँ तो नहीं है अच्छा ठीक है
I think she told me she fell from these hospital stairs. तो पेशेंट्स telling me वो अपने के पास अभी लेकिन यहाँ पे बहुत
हमारी क्लास हमारे कहाँ रेजिडेंस है तो मैं इधर बैठ रही हूँ अब मैं लेती हूँ
Good afternoon, respected Director Ma'am, esteemed speakers, faculty, colleagues, and postgraduates. On behalf of Guru Nanak Eye Center, it's a great pleasure to welcome you all to today's CME on targeting vision loss intravitreal regimen. After a successful hands-on lab session on the techniques of intravitreal injection, it is now time to move on to our academic session focusing on intravitreal drugs and its clinical applications. As we commence today's CME, I warmly invite our respected Director Ma'am, Dr. Meenakshi Ma'am, for the welcome address.
Hello, it gives me great joy to welcome the delegates, although I don't know whether it's too cold or people are too busy with other things. So I hope you had a nice hands-on session, and sessions like this give us opportunity to learn, especially the young students and young and upcoming surgeons, so that they can practice in supervised conditions and then translate that practice into their clinical practice. And this is one of the things that all ophthalmologists can practice. This is something which everybody should know. It's not just the retina specialist. So I hope you had a good hands-on session. Now, today we'll be having the theory classes also. So it's good to know the techniques and the indications and of course the safety profile. And for this, we have our own faculty and we have guest faculty, Dr. Rohan Chawla. So Dr. Rohan Chawla is currently at RT Center AIMS. He's a professor there and is quite a capable, and I would say that he is from, I'm proud to say that he's from MAMC. Undergraduation is from MAMC many years back, so he's not really a guest speaker, I would say. And really thankful that he could take out his time from his busy schedule. And also we have others, faculty like Dr. Bhumika Suri, who's a senior retina surgeon, and Dr. Bhumika, and they will be conducting this session. So I hope you all have a fruitful, insightful look inside the anti-VEGF therapy. Thank you.
Thank you, ma'am, for the kind welcome address. I would request Dr. Meenakshi ma'am and Dr. Rohan sir to come on the stage and take their seat. May I now request our first speaker, Dr. Punita ma'am, to deliver her talk on intravitreal anti-VEGF indications and techniques.
Ankur, it has come. Honorable Chairperson, my dear friends, I'm going to talk on intravitreal anti-VEGF indications and techniques. The VEGF is responsible for physiological vascular growth as well as neovascularization. And the types A, B, C, D, E, and placental growth factors. They're specific for vascular endothelial cells and act as endothelial cell mitogen. So angiogenesis is formation of new blood vessels by sprouting and splitting of existing vessels. The classification of VEGF is the archetypal member is VEGF A, and others are placental growth factor B, C, D. There is E also, and now F has been discovered in the venom of snakes. Now these are the VEGF receptors R1, R2, R3, and the VEGF A, B, C, and they get attached to these receptors in order to act. The various pathologies lead to the retinal hypoxia, and this leads to the upregulation of target cells for release of VEGF A, and this leads to breakdown of blood retinal barrier, lead to macular edema, and increase in the endothelial cell migration and proliferation and survival lead to neovascularization. The functions are given as this: VEGF A causes angiogenesis, chemotaxis, and vasodilatation. B causes embryonic angiogenesis. C causes lymphangiogenesis, and D causes development of lymphatic vasculature surrounding the lung bronchioles, and placental growth factor causes vasculogenesis, angiogenesis, and wound healing. The anti-VEGF decreases the abnormal and harmful new blood vessel formation, decreasing the leakage and swelling of retina, and leading to the stabilization of vision and even improvement. So there are different anti-VEGF, which is pegatinib, bevacizumab, ranibizumab, and aflibercept. Pegatinib is an aptamer, and specifically it binds to VEGF-A isomer. It was in use from 2004. Bevacizumab is a monoclonal antibody, binds all VEGF-A isoforms. Ranibizumab is antibody fragment and binds to all VEGF-A isoforms with higher affinity than bevacizumab. Aflibercept is a fusion protein. This is binds VEGF-A with higher affinity than bevacizumab and ranibizumab, and also binds VEGF-B and placental growth factor. So this is a highly targeted drug therapy, and therapeutic agents injected into the vitreous cavity, which maximizes drug delivery and reduces systemic complications, most commonly and routinely performed at present. So pegotinib, which is not using nowadays, is a aptamer, and it specifically binds to VEGF isomer 165. And this is a protein that plays critical role in angiogenesis and increased permeability, leading to leakage, and therefore these are two primary pathological processes which are involved in neovascular age-related macular degeneration. This is how it prevents this VEGF to act and cause the visual deterioration and other anatomical dysfunctions. Bevacizumab is a recombinant full-length humanized monoclonal antibody, immunoglobulin. It inhibits all the form of VEGF-A. It is injected intravitreally and intracamerally in the dose of 1.25 milligram per 0.05 milliliter and penetrates retina and choroid. Toxicity is category C. This means that animal studies have shown of fetal harm in pregnancy. So, off-label drug, I just want to describe. The off-label drug is practices prescribing approved medication for purpose, patient group, dosage, administration rule, which is not officially approved by bodies like FDA. So, Rosenfeld were first one to describe the off-label use of bevacizumab in 2005. So since it's a full-length antibody, its molecular weight is also higher, 149 kilodaltons. It's longer acting, average is 11 to 50 days. Plasma half-life is 20 and vitreous is 5 to 10, and metabolism is by opsonization via reticular endothelial system, and mechanism of action is bind directly to the VEGF to form a protein complex which is incapable of further binding to any receptor site of VEGF. Therefore, it reduces the effectively available VEGF. Ranibizumab is a recombinant. Recombinant means produced through genetic engineering. Humanized means that it is the gene sequences similar to that of humans, and protein sequence is similar to that of humans, but though it is laboratory made in other species. Immunoglobulin kappa isotype monoclonal, that is lab-made protein that acts as substitute for natural antibodies. It is an antibody fragment which binds and inhibits VEGF. So its molecular weight, since it is antibody fragment and not a full antibody, its molecular weight is lesser than that of bevacizumab, that is 48 kilodaltons, and it produced by E. coli expression system. Mechanism action is binds to all isoforms of VEGF-A, including biologically active proteolytically cleaved form, and It prevents it from interacting it with the receptors 1 and 2. So it's is commercially available in sterile, colorless to pale yellow, preservative-free preparation with pH 5.5, and vial packs are 2.3 milligram per 0.23 milliliter and 1.8, and in the pre-filled syringes are also available. It is stored at 2 to 8 degrees. It's protected from light and for single use only, the pre-filled syringes. And FDA approval has been obtained in these years for the diseases like AMD, CRBO, macular edema, diabetic macular edema, and diabetic retinopathy. So aflibercept is IDEA, the trade name, and it is recombinant fusion protein that is formed from combination of VEGF binding portion from the extracellular domains of human VEGF receptor 1 and 2 with that of FC portion of human immunoglobulin G. So it is a combination protein. So advantage of this is that higher affinity for receptors than ranibizumab. It's longer duration of action. It's less frequent dosing is required, and it's shown its effect in patients who are not responsive to Lucentis. That is ranibizumab. So this is a comparison between these drugs, and we see the trade name of pegaptinib is Macugen, then Avastin, then Lucentis, then Eylea, and approval for these diseases there. And the dose is 0.3 milligram, 1.25, 0.5, and 2 respectively. The half-life is 2 to 4 days for first one, 7 to 10 days for bevacizumab, and 5 to 7 for ranibizumab, and aflibercept is 8 to 9 days. The advantages: low immunogenicity and selective action in pegaptinib. And bevacizumab is cost-effective. Everybody knows it's less costly, it's longer acting, and ranibizumab is more prospective and safety efficacy data. Number of studies are there on which they have accepted the data, and aflibercept has greater affinity for VEGF. So disadvantages are the cost and serious risks and thromboembolic phenomena, which I'm going to describe later on also. So newer anti-VEGF drugs are pazopanib, the trade name is Votrient. It is an anti-VEGF used in cancer patients. Brolucizumab is a single-chain antibody fragment. So it is used for diabetic macular edema and wet AMD. Bevacizumab is a siRNA, which is small interfering RNA based on anti-angiogenic, which is anti-angiogenic for this diabetic macular edema and wet AMD. And there is intravitreal sustained release depot formulation of bevacizumab, which is available. And faricimab has its brand name is Vabysmo, and that is bispecific monoclonal antibody that binds to two agents. One is blocks the action of VEGF and second blocks the action of angiopoietin 2. So pazopanib is a multi-targeted tyrosine kinase inhibitor which acts by blocking several receptor tyrosine kinase, including those of VEGF. So inhibits receptor 1, 2, 3 in this manner, and also platelet-derived growth factor. It can be given topically as eye drops in the form of 5 milligram per milliliter, 10 milligram per milliliter. And some authors have studied if daily drops can reduce the need for intravitreal ranibizumab, but they have found that it has failed to reduce the frequency of ranibizumab injections. So we have to give as frequent as before. Brolucizumab is a humanized single-chain antibody fragment, and it is, since it is antibody fragment, so it is small in size, inhibits all form of VEGF. Molecular weight is least, that is 26 kilodaltons, and it has got smaller size, higher affinity, and greater tissue penetration. And administration of high drug concentration allows longer treatment effect and reduced need for lesser number of injections. Convercept is anti-VEGF is approved in China but not in USA. It blocks VEGF-A, B, and placental growth factor, structurally similar to aflibercept, except it contains an extra domain of VEGF receptor 2, longer half-life, less frequent dosing, and higher binding affinity to VEGF. So Aurora and Phoenix clinical trials have been used in neuromuscular AMD, have shown that excellent visual acuity gain is there, and there is reduction in retinal thickness. So faricimab has phase 3 trial is over, and once in 4-month injection it binds with, as I told, 2 places VEGF-A as well as angiopoietin 2. So common indications are I've already described before: AMD, DME, CNVM, muscular occlusion, neovascular glaucoma, and vitreous hemorrhage. So other indications in posterior segment includes ROP, Hill's disease, refractory post-surgical cystoid macular edema, and Port's disease. And anterior segment is iris neovascularization before keratoplasty to reduce the cornea neovascularization, pterygium and trabeculectomy to modulate wound healing. So combination therapies are also there, like along with PDT and along like intravitreal triamcinolone for diabetic macular edema, effectiveness is increased if it is given along with anti-VEGF. So there is triple therapy also, anti-VEGF plus PDT plus corticosteroids, and then along with radiation in cancers like uveal melanoma to increase the effectiveness and minimize damage to the healthy tissue. So benefits obviously are reduced recurrence and reduced requirement for injections. So contraindication for anti-VEGF are fibrovascular proliferation, FVT, threatening the macula, active ocular or periocular inflammations, hypersensitivity to the drugs, uncontrolled hypertension, cardiovascular disease, pregnancy and lactation, and pre-pubescent children should not be given. So the complications include raised intraocular pressure, cataract, endophthalmitis, thromboembolic phenomenon, rebound macular edema, immunoreactivity, retinal detachment, and central retinal artery occlusion. So trials, there are different trials like in BEAT, ROP, and Rainbow for ROP, bevacizumab, and ranibizumab, and then in diabetic retinopathy there is READ trial, BOLD, Da Vinci, VISTA, and VIVID, DRCR protocol I, T, and S, which is comparing the anti-VEGF versus lasers, and whereas as have been shown that ARP versus ranibizumab. Then retinal vascular occlusions, BRVO Bravo trial with ranibizumab, Marvel, Vibrant, that is aflibercept versus laser, Brighter, ranibizumab versus laser, and Burwood. And CRVO's Cruise, Copernicus, Galileo, and SCORE 2 trials. And in PCV, there is Laptop, Everest 1 and 2, and Planet. Myopic CMM repair and radiance. So technique is that we have to dilate the pupil and topical anesthesia has to be given, clean and break the eyes. 5% povidone iodine has to be kept for 5 minutes in the interval sac. Wire speculum is applied, drug is taken in a tuberculin syringe with 30 gauge needle on it, and patient is asked to look in the direction opposite to that of injection site. It is administered generally in supratemporal and infratemporal quadrant after visualizing the needle tip in the vitreous cavity. In 1 to 6 months old, it is at 1.5 millimeters, 6 months to 1 year, 2 millimeters, 1 to 2 years, 2.5 millimeter from limbus, 2 to 6 years, 3 millimeter from limbus, and 4 to 6 years, it is 4 millimeter in phakic, 3.5 in pseudophakic, and 3 millimeter in phakic. The injection site is after injection, it is pressed with a cotton bud immediately, but not too much pressure has to be exerted so that the drug does not regurgitate out, and the patching of the eye is done. So injection sites, supratemporal has advantage at ease of access, and it can be used for pneumatic retinopexy also. This site, but so injection site infratemporal is preferred due to the Bell's phenomenon. So this is the video for describing the injection, and this ranibizumab injection is planned. And this has been done for this striated macular edema as shown. Dosity. 5% betadine is given for 3 minutes. Wash with balanced salt solution. Measurement with calipers. Here 4 millimeter in the phakic eye. Point of injection is marked with the calipers. Supratemporal area and the pars plana region. First, the air is pushed out so that air doesn't get injected in the vitreous cavity, because it will also occupy some space and cause a rise in the intraocular pressure. So after taking out air, then 30 gauge needle is mounted on the tuberculin syringe which is carrying the drug. Conjunctiva is retracted with a cotton bud so that scleral entry point does not coincide with the point of conjunctival puncture. Needle traverses first short oblique path and then perpendicular so that beveled type of entry is there. Drug is injected slowly in the vitreous cavity. The needle is taken out. Cotton bud is placed to point the tamponade. To prevent the drug also and to prevent vitreous also coming out from there. The treatment is not done and hence the procedure ends. So post-operative care needs that first step, sentinel examination and fundus examination for all the complications like any inflammation or detachment or hemorrhage, then IOP monitoring for rise, symptoms of infection to be explained to the patient, that is head bath after 2 days, and pre and post-op antibiotics to be used and follow-up is after 1 month. Thank you.
Thank you, ma'am, for that insightful session. May I request Dr. Meenakshi ma'am to kindly felicitate Dr. Punita ma'am. Next, I invite Dr. Bhumika ma'am for her talk on intravitreal drugs in endophthalmitis, which when invited.
Good afternoon, everyone. I'm going to discuss the role of intravitreal drugs in endophthalmitis. When to use them, what combination to use, and what is the rationale behind that choice of that combination. So, we all know endophthalmitis is an infective, vision-threatening condition. It's a nightmare for the patient, for the operating surgeon, as well as the VR surgeon, if they both are different. So, it's an infective condition which we can get post-surgical. There's a list of surgical options which can result in this: keratitis associated, post-traumatic, and endogenous. The question comes here is when to inject. Is there an appropriate time? We need to realize that endophthalmitis is a race against time. There's a ticking bomb right there. Every minute we lose, we have the organisms which are growing, the inflammation which is increasing, and the prognosis which is reducing. So we have to hit when it is hot. So what is the correct time? If you have a confirmation, very good. But even the suspicion of it, or to buy time when the two sides are not agreeing on a thing, is the right time to move on with the intravitreal drugs. Now, why the intravitreal route? We have so many other routes. Why intravitreal? We are hitting directly at the target. So you inject directly at the niche, you take a sample directly from the niche. So which you need for identifying the organism, for your culture sensitivity to cater to the antibiotics which are suitable for that organism with minimal side effects. So that's the reason why we consider intravitreal the most important. And somebody has made so much of effort to, categorize the effects of this drug. So why can't we be so appropriate in our measurements? Giving the correct dosage is very, very important. You reduce to what is required, you end up with a treatment failure. And if you give more, please remember, more is not always good. You land up with retinal toxicity, which is as worse as what you're dealing with. So this is a table which shows the most commonly used drugs and their combinations with their dosages and organisms covered. So from times immemorial, we've been reading about vancomycin, which still holds the bait for the gram-positive bacteria. For gram-negative, we have shifted from amikacin, which lost its fame because of retinal toxicity, to these days going to ceftazidime, which covers the gram-negative mode. And cefuroxime, which is a second generation cephalosporin, has a broader coverage. And for fungal, we have the options of amphotericin B and voriconazole. This is just a list of most commonly used. This is not the complete list. And steroids, we have our options. So are we just limited to this? No. This is the complete list. So that is why I said getting down to the organism, getting your reports for culture sensitivity is very important to pick up the correct combination from what we have on the screen. So there are drugs which are still under trial, which are in the red box. They are not to be used, please. But the rest of the drugs are all approved. And you can pick up your combinations according to the culture sensitivity reports that you get. So whenever I talk of endophthalmitis, whenever you sit in the exam, what we always expect to be asked is endophthalmitis vitrectomy study. This was conducted way back in 1995, especially for the acute post-cataract surgery endophthalmitis. But in today's world, with better technology, better equipment, wing system, medications, does it hold true? So where do we go now? We have EVS and we have complete early vitrectomy for endophthalmitis. So what do? We go back and rely on an old study, or do we rely on what is currently being talked about? Well, to discuss and to know about the role of EVS in today's era, there was a nice study which was published in IGO in 2025, which was the preferred practice patterns amongst the members of Vitreoretinal Society of India. And let's see what it says. So I'll just quote the study for you to have a literature background, whether that holds true today or not. It still says that the most common form of endophthalmitis reported is post-cataract surgery endophthalmitis. And more than 50% still perform vitreous or anterior chamber tap with a needle along with intravitreal antibiotics, despite the fact that they all have access to modern vitreoretinal surgical setup. So this is an important take which I would want you to pick from this slide. When we come to post-operative fungal endophthalmitis, yes, surgical is what most people prefer. Vitrectomy with IOL explantation. But when we come to the antifungal drugs, voriconazole takes the bait from amphotericin B. So more commonly used is intravitreal voriconazole in 35% who prefer than amphotericin B. Post-traumatic endophthalmitis. So here they are divided into two different categories. One, when the primary wound repair was done somewhere else, and with endophthalmitis, the patient was referred to, which was 57.8%. And the rest had the patient presenting with an open wound and endophthalmitis at the same point of time. Either case, they did a primary wound repair and intravitreal antibiotics was given during the same time. The only difference between the two groups, which says 27.8, had a vitreous biopsy or tap, and the rest deferred to do so because it was an open wound. Then, what happens when you have an infected cornea? 32.3% still prefer to do intravitreal antibiotics. 31.6% prefer to do vitrectomy with temporary keratoprosthesis along with intravitreal antibiotics. Core vitrectomy with intravitreal antibiotics is another option. I cannot emphasize more on the choice of this technique in this disease any more than the literature that I'm quoting. So then what is the choice which is being done, what is being picked up these days? Whenever we talk of post-cataract surgery endophthalmitis, if the patient is presenting on day 1, Vanco and Cefta combination still holds true in most of the patients. And the other surgeons prefer to give vancomycin in a combination of tazobactam and piperacillin. Whereas when it comes to day 3, again, Vanco-Cefta leads. So most respondents perform vitreous or AC tap with intravitreal injections as appropriate according to the condition as the initial management protocol is what the study quotes. What is the role of steroids here? Is it thumbs up or is it thumbs down? Again, I always say everything comes with a background literature. The current survey says that more than 50% respondents would prefer giving intravitreal and systemic steroids. Please make sure that I'm not talking about the fungal endophthalmitis here. Right? So why adding steroids? It is, the literature again says, the half-life of the antibiotics which you inject intravitreally is shorter without steroids. And I would end with some special situations. What happens when you have silicone oil filled eyes? You should give an intravitreal or you should not? Or you should just let the things progress as they are. So what happens when there's a silicone oil filled eye? Basically, the available aqueous volume is reduced, hence increasing the peak concentration intraocular drug. So for the hydrophilic drugs like Vanco and ceftazidime, you can reduce the dosage to 25 to 30%. Again, there's a study which I'm quoting here, Survey of Ophthalmology, which was published here in 2024. So they had 2 sets of patients. In one, they gave a standard dose, and in the other, they reduced the dose by 30%. And both the groups had an equivocal result. So you can reduce the dose for hydrophilic drugs when there's a silicone oil filled eye. And what happens in the vitrectomized eyes? So all you have to remember is they have a shorter intraocular half-life and accelerated drug clearance. So standard dose but more frequent dosage is what is required or is the need of the hour in the vitrectomized eyes. And this chart, I always say this is a bliss for all the residents. Make your dosing correct. How to make it, just knowing about the doses is not important. You have to make it in the correct manner. This chart, I think, is available in every operation theater, wherever you go. So this, please follow stringent rules to make your intravitreal antibiotics. Thank you.
Thank you, ma'am, for making such a complex condition with such clarity. May I request Dr. Meenakshi ma'am to kindly felicitate Dr. Bhumika ma'am.
Now we all know why she got a gold medal.
It's my privilege to invite our guest lecturer, Dr. Rohan Chawla sir, for his talk on alternative therapies or drugs through intravitreal route.
Thank you so much. First of all, I would like to thank Dr. Meenakshi and all the faculty of Guru Nanak Eye Center for calling me here. And like ma'am said, it's my own place actually. My alma mater, I did my MBBS from here. And so it's really, very nice to be back. I think MBBS was one time where you enjoyed the most. So for the residents, now you have already passed MBBS, but I think that's where you make most of your friends. I still have a lot of friends from MAMC. So please enjoy your time here and please do learn a lot from all the faculty and the practical experience. So okay, so before I start, can I just make a few comments on the two nice talks which you have just heard? So they were quite comprehensive. So just regarding the technique, from my experience, one thing I would like to say is one important thing is you have to prevent hitting the lens. So be very careful about the direction of the needle. You would have had the hands on there. So I generally prefer to give it under the microscope, but now when we have a lot of patients, many times a lot of our residents are doing it without microscope also. That's a very valid technique. But just be very careful that the once you are injecting going into the eye is straight. It's not tilted downwards or somewhere, and your angle of the needle should be towards the center of the eye or towards the optic disc. It should not be angulated towards the lens. So that is one common complication which can happen. Just prevent that. And second, the intraocular pressure sometimes can go up if you have by mistake injected a little more or nothing came out extravasated and the pressure went high. So always just before sending the patient out, I just ask the patient to count fingers. If the patient is counting fingers, you know that the pressure is not above the central retinal artery pressure. So do not cause the CRU. If the patient is not counting fingers, then it might be then better to do a paracentesis. And I always ask if patient does not have sulfa allergy, we generally give one tablet timeouts immediately post the injection. Just small points which you should take care of. And regarding ma'am's talk, lot of drugs is already mentioned and part of my talk. I think just very easy. One or two drugs you mentioned, imipenem, that one we have recently started using for some of the fulminant cases, gram negative, which don't respond to anything. So 100 microgram or even 150 microgram imipenem we have started using in some cases. Not as first line, you're right, but yes, we have started. And out of the antifungus, I think I'll come to that also in my talk. Voriconazole has a little disadvantage, it has a shorter half-life. Although initially all of us started using it a lot, but the half-life is only 24 hours, so you have to give more frequent injections. So that is why again in fulminant cases we prefer amphotericin B or some other combination. And otherwise, so let me start with my talk. So I'll be not talking of the most common impact which are the anti-VEGF agents, but the other agents which also can be given intravitreally and which would help save sight. So I think let me make it a little more interactive for you. So anyone, can you tell me what do you see in this? What could be the possible diagnosis? Any of the residents? Anyone, please go ahead. So this is a wide field fundus photograph. So these dots, these are the asteroid hyalosis. But other than that, you can see that there is venous tortuosity, there is dilation, there are hemorrhages in all four quadrants. So this is basically a case of central retinal vein occlusion. You do a fluorescein angiography. The aim of doing this was here probably to see how bad is the capillary non-perfusion area. Is it an ischemic type of CRV or the non-ischemic type of CRV? So here you can see not many capillary non-perfusion areas. Is this a marker? No. So you can see that the black areas are not too many. Most of the areas you have perfusion. So it is an ischemic type of CRO. But when we do OCT, we still find macular edema. So yes, definitely here also there is an indication of an intravitreal injection. You can go ahead with an anti-VEGF, or the other option as per as this core study is that you can also go ahead with steroids. So the SCORE study tested two doses and they found that the 1 milligram dose was also quite effective and the incidence of glaucoma and cataract was less with the 1 milligram dose. So we can go ahead with the triamcinolone 1 milligram injection in central retinal vein occlusion. Also, there are other studies with Ozurdex which have also said in that vascular occlusions you can go ahead with steroid injection. But as a first line, would you do that? Well, I would say that anything which can have some side effect, why use it as a first line when you have another option? So yes, even today I would say anti-VEGF would be the first option. But if patient has received multiple anti-VEGFs and there is not much response, maybe not more than a 10% or a 15% reduction in the macular thickness or OCT, I would shift to a steroid. If patient can afford, Ozurdex. If patient cannot afford, triamcinolone 1 milligram is also a very good option. Especially in phakic patients, I don't want to directly go in with a steroid because they will end up getting a cataract. And also, before you use steroid, be sure that there is no predisposition for glaucoma. You are already seeing cupping, you are already seeing pressure is high, then why go ahead and give a steroid? So, looking at all that, if everything is fine, then you can go ahead and give a steroid injection also. Some cases where the edema is too much, say 800 microns, then sometimes I do prefer going with steroid straight away also, because the overall drying effect of steroid is quite good. So this I have just told you. So you can use it for CRBO, you can use it for BRBO, and even in diabetic macular edema when the case is refractory, or some indications are that if there are a lot of hard exudates. Some studies have found that hard exudate resolution is little more better with steroids. You can go ahead with that. There are some studies which have shown that if there are too many hyperreflective dots on OCT, then also you can go ahead with steroids, but that we rarely follow. Mostly, if it is a refractory case or there are too many hard exudates, we combine it with anti-VEGF or independently, or if there is a contraindication, like patient has had a stroke or an MI in the recent past 1 or 2 months, then I don't want to give an anti-VEGF at all. If there are any collaterals forming in the brain or the heart, why to disturb that? Even with whatever little systemic absorption, your anti-VEGF is going to happen from the eye. So for if a patient has had a recent cardiovascular event or a stroke, better to avoid anti-VEGF for 3 to 4 months. So in that period, you can, if you at all you want to inject, better to give a steroid. And sometimes in Coats disease also, you want to give steroids for a temporary reduction in macular edema, but the final management would be with laser or cryo. You would have to manage the peripheral vascular anomalies. Okay, anyone, what's happening to this patient? These are two fundus images. Can anyone describe what is happening? What they can see?
Choroiditis acute.
So ma'am is saying choroiditis. So why could it be choroiditis?
Residents, please be more interactive. Come on, you all know it.
Yeah. Okay, so you see these yellow patches here, and you see that over these yellow patches also some of these you can see the blood vessels. So either these patches are very deep retinal or choroidal, and the margins are a little blurred, so it seems to be a more deep pathology. So it is an inflammation which is choroiditis, and which is in this pattern sort of form. So you can call it a geographic GHPC or a serpiginous sort of form. So we call it a serpiginous choroiditis. Again, in this eye also, you are having this yellowish margin which is the active, and the central part which has already started showing healing. So it shows a centrifugal sort of healing. Center part heals, but the periphery remains active. And here it is very close to the macula. It is macula threatening. Even here it is very close to the macula. So here again, I want something to hit very hard, very fast. If I give, I will definitely give oral steroid, but that will take some time to act. So additional to that, either some people will give pulse intravenous methylprednisolone, or the other option is once you have ruled out infectious causes like syphilis or rarely TB, which can also present in this manner. So all those investigations might just take a day or two. Once you rule that out, you can also give an intravitreal Ozurdex or an intravitreal tripod here. So we have done many cases with intravitreal where patient does not or cannot receive a pulse steroid and they have responded quite well. So, okay, another case here. So what do you see here? So here, these lesions are similar to what you would see in a patient of retinitis pigmentosa. This is a case of retinitis pigmentosa. But along with that, the patient also developed floaters, had AC cells, vitreous cells, and this lesion over here. Now this lesion is different. You see, it is covering the blood vessels. So it is a retinal lesion. So either it is a retinitis or it is a granuloma in the retina. So, but this patient again started having inflammation in the retina, and when we do an OCT, I don't have the OCT through that lesion, but OCT through the macula also shows you the cystoid macular edema. You carefully see here, even clinically, you will be able to make out these red radiating slight lines or a petaloid pattern. So even clinically, you should be able to pick up the CME here. But you can see the CME and you can see the vitreous cells. So again, a patient having inflammation in one eye. So same way, you can even give steroids in such a patient, intravitreal Ozurdex, and patient will respond well. So in uveitis, wherever you have serpiginous choroiditis which is threatening the macula, or you have a cystoid macular edema due to any reason, even a case of vasculitis, you can. One option is that you can use an intravitreal steroid other than systemic steroids. So depending on how fast you want to have the action, or if the patient has some contraindication to systemic steroids, once you rule out an infectious cause, this is a very viable option. So this is the general dose. Earlier we were giving always 4 milligram, but now we have reduced 1 milligram. Sometimes in these cases less. We generally go with 2 milligrams. And other implants are also available. Close known implant, but that is not in India. What best we have is the Ozurdex. So that is, but the cost is a limiting factor in certain patients. So So another case, anyone? Just describe someone. What are you seeing? What are you seeing here in this image?
This is a
So you see all those white patches, multiple white patches here again covering the vessels, and you are seeing hemorrhages along with that. In this area, in this image, again those white patches with some clearing and some pigmentary mottling and some hemorrhages here. So when you have, and if you see along these vessels some deposits in the on the arterial wall. So again, first of all, this is retinitis, which is happening in the eye. You have to recognize it is not choroiditis. And then, according to the history and investigation, might probably you'll come to the final diagnosis. If I tell you that this patient is immunocompromised, then the first diagnosis becomes CMV retinitis in this case. Okay. Although rarely, sometimes herpetic also can present this way, but if I tell you immunocompromised and this typical feature, which can sometimes be granular or which can sometimes be, if you have more hemorrhages, I would have called it like a pizza pie. So then you would definitely call it CMV retinitis. So in cases where you have infection, viral retinitis, then the drug of choice again is ganciclovir. So another presentation of the same similar variety. So you see, you have here two different manifestations. This is more of the pizza pie sort of appearance where you have the ketchup and the white cheese, and here you don't have that. Here you just have a granular variety. Both manifestations in the same eye with these uh, small dots. And you see here it is retinitis, it is inflammation, but the image is so clear. So no vitritis, very minimal vitritis. Why? Because the patient is immunocompromised. Had it been a viral retinitis in an immunocompetent patient, generally we would have found more vitritis in this eye. So mostly again the diagnosis becomes CMV retinitis here. And what we would do is we come to the drug. So this is on the other hand the other sort of patient which I was saying, where you see the picture is not very clear, hazy. There is vitritis. You can see some disc margins are blurred, hyperemic disc, and white patches, but more in the periphery and spreading centri like in an arc manner. So all along in the periphery they are spreading, arcuate spread. So this is acute retinal necrosis, which is more commonly by the herpetic group of viruses. So here, what would be the therapy of choice? So here, the therapy of choice ideally would be either IV acyclovir or oral valcyclovir. You can complement it by an intravitreal injection of ganciclovir. Ganciclovir does not have major effect on herpes group of viruses; it has more on cytomegalovirus. But in vitro, it has shown activity against both, so you can complement it by an intravitreal. But here again, the mainstay is valcyclovir, whereas in the previous cases which I showed you, here the first therapy of choice would be ganciclovir. So I think I have that. So these are the other features you can see of ARN. So ganciclovir, the dose is 4 milligram to 6 milligram. Earlier we were giving a lower dose, 2 to 4 milligram, and we had to inject twice weekly. But now some studies have shown that if you give a higher dose, 6 milligram, you can inject only once weekly. So we have shifted to that. We are using 6 milligram once weekly. Phoscarnet, cidofovir are other options for resistant cases, but they are not available in India. To especially get them for some patients, I have not used them. So they are little problem. The problem for us, but most important drug which we use is, if at all, intravitreal is intravitreal ganciclovir. Okay, so in other case, anyone? Again a white lesion. So white lesions are little difficult, but so
it is involving retina only.
again involving retina, yes, because and it has more well-defined margins other than the edema over here surrounding. But it is, as opposed to what images I showed you earlier, it is a very localized, more focal lesion, and it has
Vitritis is there.
little bit of vitritis. Maybe you might say photo to अच्छी है, but still, if you see there are some vitreous cells you might be able to appreciate on the OCT, and you might be able to appreciate on a slit lamp examination some retrolateral cells. And when you see with the indirect and compare with the other eye, you would know that there is slight vitreous as compared to the other eye. So a very typical appearance of a headlight in a fog. So first diagnosis here is toxoplasma. So the first suspicion that you would make is toxoplasma. It can be other things, but the first suspicion that I would have is toxoplasma retinitis. So, again, you do an OCT through the lesion, you can see that all the hyperreflectivity is in the retina, not in the choroid. So it again confirms my suspicion that is the retinitis which is happening first. which may spread to the choroid. Retinochoroiditis can happen. And again, this partial hyaloid secretion and cells in the vitreous all tell me the clinical picture that it is toxoplasma. I can confirm with the serology, but that is not what is diagnostic. Diagnostic generally is taken as the clinical suspicion. Again, the drug of choice here would be oral sulfamethoxazole and and trimethoprim combination. But now we have another option, intravitreal clindamycin. So you see, all these points tell me that this is more likely a toxoplasma lesion. So you have that fog, you have fewer hemorrhages, no heart exudates, but sometimes it can also have be very severe associated with an exudative RD. So here now, times we also inject clindamycin, especially if it is threatening the macula. So I want to hit again hard. I will start the oral. I will also give a clindamycin. Why wait for so much long? But this again can have its retinal toxicity, as ma'am mentioned. Some drugs can have toxicity, so I cannot be given very frequently. If at all, repeat after a week, and generally not more than 2 to 3 times. So, but this is an adjunct to therapy for toxoplasma. This has already been discussed quite a bit in detail. Patients with your hypopure, your corneal involvement, cells in the anterior chamber. So this is acute postoperative endophthalmitis. The management for these would be all the antibiotics which have been discussed. And if the patient does not improve with intravitreal antibiotics in 24 to 48 hours, then better to go ahead with a vitrectomy. And choice of vitrectomy also, madam mentioned in some slides earlier, either it's core vitrectomy or total vitrectomy. So the EVS study classically talked of core vitrectomy, but now we know that we should do a little more than core vitrectomy. But again, what we say is do a safe vitrectomy, because sometimes the visualization is not good, and if you want to do a total vitrectomy, take the periphery, take your vitreous cutter too much in the periphery, you can create iatrogenic retinal breaks and all. So avoid that, but do a safe vitrectomy, and again, after the vitrectomy, inject intravitreal drugs. What concentration? You can reduce it by 25 to 30%, but not more than that. So again, it has to be followed up with the antibiotics and followed up with the culture reports. If the culture comes positive, gives you a sensitivity, it helps you. If it doesn't, then you are blindly treating, but then we will give those broad spectrum antibiotics. So vancomycin was gram positive. Dose is standard dose is 1 milligram, but now some studies have shown you can go up to 2 milligram. And for ceftazidime, madam has told you the dose. Other option what we have is piperacillin, tazobactam, or imipenem, like I just said. You know, again, this patient tell me. So these are now two patients I think which I saw during the COVID period. So they were having COVID, they were receiving steroids, they were receiving intravenous drugs, and then they came up with this loss of vision. So what are you seeing here? Again, a yellowish, whitish, creamy lesion at the macula. But just by this, maybe you cannot make a diagnosis. You have to see the patient in photo. The patient also has EC cells. Patient also has retroretinal cells. So I would say this is an inflammatory pathology. And in view of all those things happening in the background, there will always be a high suspicion that the patient has developed endophthalmitis endogenous. So we took it as endogenous endophthalmitis, and we were aware that all those things, fungal infections were very common. We took it as a fungal infection. We did a tap. So instead of taking a vitreous sample through the needle, you can also take by these days you can just introduce a 25-gauge trocar cannula, and with a cutter you can take a sample. So that reduces the chances of complications. We sent the sample also, and it started injecting antifungals. So again, not just injecting. When it is an endogenous endophthalmitis, the treatment of choice is intravenous therapy. But again, you can add on other therapies so that you are hitting in all forms with multiple directions to get the maximum response. So here you have a focal lesion, again some vessels over it, so you think it is appearing at a deeper level. So that means endophthalmitis most commonly comes from the choroid into the retina. So it is at a deeper level, and the margins are also fluffy. You do a OCT, you can see that the lesion has already come into the retina also from the choroid, and there are cells. So we treat it as endogenous endophthalmitis and started treating. Initially, we gave voriconazole only, but we found that the patient also had this candida was there. So finally, we changed our drug of choice, and this patient we had to give amphotericin and combination with capsofungin, because that we found that candida specifically, which is not the routine candida, candida albicans. So this came out to be candida tropicalis. So candida albicans is quite sensitive to most of the drugs, but other candida are not sensitive. So we had to search for another drug we found again that caspofungin had been given in rabbits with this dose. So 50 to 100 microgram caspofungin was given, and not just one injection. These are very, very difficult things to treat. For the patient also, it's not easy for the patient to receive intravitreal injection every 24 to 48 hours. For the doctor also, it becomes that patient is not improving. You always have this, that patient is also telling you, you are giving me so many injections, nothing is happening. So it's not a very easy situation, but you have to just persist. So you persist with all the IV treatment. You can change the IV to tablets after a week or so and keep on giving the injections. So I think we gave around 4 injections in this patient, and finally we did see resolution happening. You can see that white patch is decreasing, but some hard exudates have now started developing because the outer blood retinal barrier would have broken. So some exudation from there is causing these hard exudates and scar formation. OCT can also help you monitor the response to treatment. And finally, this was the final scar. So patient's vision would probably have been 660 or 636, not more than that, but at least we have salvaged some sight and prevented this eye from going further, probably into a panophthalmitis stage. This is another case. This patient again was after 3 weeks post-COVID. Our left eye patient had been operated outside, and unfortunately that eye was lost, no PL. And he came with some floaters. And what we noticed is there's just one lesion there. It's away from the macula. Patient lesion is 6/6. Now very tricky situation. This patient, I think Dr. Kirti only had sent from here. So very, very tricky situation. Now patient has 6/6 vision, only one eye, what to do. But you have the highest suspicion of metastatic endo of the other eye, already proven endophthalmitis. So we again started, again the scan shows that the region has all involved the retina, but it has not broken the eye level and not gone into the vitreous. So we were still hesitant that let's not do vitrectomy. We would maybe open up the route for infection to spread. So let us just limit ourselves to the intravenous route as well as the intravitreal therapy route. So again, we treated the patient same way, and we gave multiple injections. We combined everything. This patient received about 6 to 8 injections, I think, and finally it started showing some response. And again, the height reducing. You can still see so much of cells in the vitreous, and it's scarred. This is all the drug floating in the eye. And finally, this patient is stable at 6/9 vision. Now I've been following up for 3 years. So only thing is that fungal endophthalmitis is very difficult to treat. If it is post-operative, then also if it is endogenous, then also. But the only way to treat is by multiple ways. Go ahead with systemic therapy, go ahead with intravitreal, and at one point of time, if you feel that it has broken into the vitreous, there is vitreous haze developing significant, then there is no way out. You will have to resort to vitrectomy also. So this article I just wanted to show you. Mostly when we talk of endogenous endophthalmitis, we say that the infection comes from the choroid. But this article has recently shown that sometimes, especially in fungal endophthalmitis, there are of two types. Sometimes it might also come from the retinal vessels, and the infection might be limited to the retina also. In some of my photographs also, you saw maybe one or two. The last case, the small lesion was of that type. It was predominantly limited to the retina only. So, and you can read this. They have described various signs also here for all these filiform lesions and the cloud burst sort of sign, where they say to see such a lesion with cells and there is a background history to it which can relate to an endogenous endophthalmitis. Like patient just like that won't develop an endogenous endophthalmitis. There has to be some predisposition, either some immunocompromised stage or some infection focus in the body somewhere. Or in our country, most common, patient had diarrhea, went to a physician, they gave him an IV drip. Just from that IV drip, candida has gone into the eye. So that is an unfortunate situation in our country. Proper asepsis is not maintained, or the bottle itself had some fungus, and that is a common cause. Intravenous therapy and patient developing a metastatic endophthalmitis. So take all those histories. You feel that is there. You feel the signs and symptoms are matching. Then that is your diagnosis, and don't delay again in that. Start intravitreal therapy fast. So again, a big list. Some of the drugs I've already told, some of these already told to you. So this dosage you must know, and definitely give the correct dose. Neither overdose, neither underdose. Okay, another case. So if you see this white field photograph, you can see the central part of the fundus, but surrounding there is a lot of haze, a lot of vitritis. We do an angiography. Through the haze, you may feel that maybe some of these vessels are getting blurred, maybe some leakage, but no definite leakage. Not much leakage at the disc or the macula itself. This is probably just a flash. But if I see such a patient with some cells and lot of vitritis, what would be my first impression? Vitritis and some cells, first impression would be intermediate uveitis. So maybe this is a case of intermediate uveitis. But if I add to the history, this is an elderly patient, 60, 65 plus. So then I always have to think of a masquerade syndrome. And the other thing is when I do the OCT, I am not seeing cystoid macular edema. So if a patient has so much of intermediate uveitis, patient is bound to develop generally cystoid macular edema also. So absence of CME with so much of vitritis also gives me something in my mind and the age that this I might be dealing with something else. So we do a vitreous tap here, I'll tell you. So this is another patient of the similar category, but this patient does not have vitreous haze. This patient is again elderly, which comes out with these punched out leopard spot sort of lesions in the RP here. You see these atrophic patches multiple. And when you do the OCT, you are see through these lesions, some of them you are seeing these bumps. Where the RP is elevated, this is the Brooks membrane and some deposit here. Something like a drusen, but this patient is not having ARMP. So what is this deposit? So again, this is the second manifestation of what I was coming to is primary vitreorectal lymphoma. First manifestation is a vitreous inflammation. Second manifestation is you can get these deposits which are limited to the retina. They do not penetrate the Brooks membrane. So in an elderly patient, if you have such a manifestation, these two things should come to your mind. The first thing I would do is do an MRI brain because many of them can be associated with the CNS lymphoma also. If that picks up a lesion, that might be diagnostic itself. Otherwise, we take up the patient for vitreous tap and biopsy, and in this we found these CD20 positive B cell lymphoma cells in both these patients. So diagnosis of lymphoma was confirmed here. So for lymphoma again, two therapies because it is a systemic disease, especially if it is bilateral with or without CNS involvement. We will give systemic chemotherapy, but we can also augment it with intravitreal therapy. So intravitreal therapy, the dosage given is methotrexate, but this is also very taxing regime for the patient, but it has to be done. Initially, you give it twice a week for 1 month, and then you give it once a week, and then you give it again slower and slower, but the therapy continues for about 8-9 months. And sometimes methotrexate can cause corneal toxicity, so we have to be a little careful about that. Other option is like these are CD20 positive cells, so rituximab is a monoclonal antibody against CD20 cells. So that has also been tried in some studies. So that can also be done, but again, little cost implications would be there. So intravitreal methotrexate, apart from lymphoma, can also be used in uveitis. It is not that effective as a steroid, but for a temporary measure, especially in cases where the IOP has gone up. So you have a patient of intermediate uveitis, IOP is 26, 29. I would be afraid of giving a steroid in that time. And suppose I cannot give systemic steroids, patient does not want to receive steroids for some reason, then this is one option I have temporary. I can give an intravitreal methotrexate. Action will not last as long as steroids. A steroid action, suppose Ozurdex, you inject lasts about 3 months minimum, sometimes even longer. You give intravitreal tricot, again the action lasts 3 to 4 months. Here the action lasts probably less than around a month or so. But still to buy time, I can give this and then add on some other systemic therapy like oral methotrexate or oral azathioprine. Those therapies will take 2 months to act. So I have to buy time for those 2 months. What can I do if the patient is not able to receive oral steroid? Then I can buy time with giving these intravitreal methotrexate. Another recent indication for methotrexate is coming up is now after many times vitreoretinal surgery. Proliferative vitreoretinopathy is something very troublesome. All of us face redetachments because of proliferative vitreoretinopathy. Again, we do not have very definite things to prevent it, but again, studies have shown that if you give intravitreal methotrexate at closure of surgery and repeat it 2 or 3 times every week after surgery, it may reduce the incidence of PVR. We have started using that also in some bad cases of PVR. Then coming wet ARMD, all of us know we have a lot of anti-VEGF drugs, but there are two drugs which are complement inhibitors, which have been approved by FDA, which are being used in US. So these are complement inhibitors. They have to be given every month, and studies have shown that they reduce the chance of progression of geographic atrophy or the number of drusen from increasing. But personally, in India, they have not even come because they're very expensive drugs, and I don't think they will even come into India. And probably slowly, even their use in US is going to reduce because I think European Union has also not approved. All the countries have not approved these drugs. They're very costly and probably being pushed a lot by pharma. But this is one of the research which has happened that in all the Brucin material they found that the complement factors were there. So that is why someone thought of giving that even the dry IMD might have some relation to the inflammatory cascade of the complement activation. So they thought of making these anti-complement antibodies and injecting them, and they have shown some benefit. But again, dosing is too much, and the benefit is not that much that we continue giving the injection. But you should know some of these could come as MCQs. Some very nice. Another indication is submacular hemorrhage. So submacular hemorrhage is a lot of hemorrhage under the retina. It is sort of an emergency for a retina surgeon. Why? Because if there is blood just under the photoreceptor, they are going to damage the photoreceptor very fast. If the blood is above the photoreceptor, if it is a subhyaloid bleed or a subhyaloid bleed, I am not that worried. It generally doesn't seep down so fast, so you can leave it for a month, 2 months, no problem. But a subretinal hemorrhage just under the photoreceptors has to be tried to remove it as fast as possible. So there are options of doing a surgery, injecting subretinal, or if one is not adept at doing that and there is no actually need for that also, intravitreal TPA injection plus minus gas injection has also shown to be a very good sort of therapy for it. So we combine this. This was a case significant submacular hemorrhage. So causes could be a PCV, causes could be trauma, causes could be just a fibrovascular CNVM. So you can do an OCT, and now you see this swept source OCT is so good that even penetrates under the hemorrhage, and it shows you that under the retina all this blood is lying there, and sometimes the RP is also lifted, so some blood is also under the RP. So the blood under the RP may not be displaced much, but the blood under the retina in the subretinal space does get displaced. So all that you have to do is inject gas. If you have TPA, you can inject up to 50 to 75 microgram. But TPA is again expensive. If you don't have, don't worry, just inject gas. And if this case is related to ARMD, then you can also inject an anti-VEGF along with it. If it is trauma, then no need for anti-VEGF, just gas. So just inject about 0.3 cc or 0.5 cc of gas, but again be careful, IOP should not go up. You have to do a good paracentesis here. You want to give such a high volume inside the vitreous cavity. Normal anti-VEGF is only 0.05 ml. So this is 0.5 ml, very large. So you have to do paracentesis very nicely, give time offs. If at all, you can also give mannitol. So maintain the IOP, inject it, and ask the patient to be in prone position for at least 2 to 3 days. Pressure of the gas will displace the blood. So this is what was done in this patient. This is a remarkable result. So patient again, see final OCT is so quite near normal. Patient does gain good vision here around 6/12. So simple intravitreal technique, no need for any fancy surgery, but you can get good results. So just to summarize what all we discussed various agents, steroids, antibiotics, antifungals, antivirals, antimetabolites, and some of these complement inhibitors, which are the other drugs which can be used apart from just the routine anti-VEGFs, which is definitely the most common intravitreal injection. And the story doesn't stop here. People are now completing, I think phase 3 studies are already on for tyrosine kinase inhibitors in the US. So what do they do? VEGF inhibitors are acting extracellularly. So when a VEGF attaches to a VEGF receptor, the intracellular changes what happen are mediated by the tyrosine kinase enzyme. So these are going to act intracellularly. They take a little more time to act. So that is why for these initially 3 loading doses of anti-VEGF have to be given, and then a tyrosine kinase injection. And many studies have shown that that can probably extend the action to up to 6 months also. So we are really waiting for these drugs. Once they are in India, probably it will reduce the burden, but cost is again going to be a factor initially. And then you have other injections which are coming up for MAC10. This is a new study where people have injected ciliary neurotrophic factor. So this is also shown to have some benefit for macular telangiectasia, for which again we did not have anything up till now. And lot of therapies coming up with adenoviruses. So gene therapies or even anti-VEGF sort of therapies, so where the required gene is formulated into the virus, and the virus is injected into the eye, either subretinally or intravitreally, and that gene, once it goes into the vitreous, it is transferred into the cells of the retina itself, and the cell becomes the factory of making those anti-VEGF molecules. Or say you might have heard of Luxturna, which is a therapy for retinitis pigmentosa. It starts making the RP65 gene product, so that maybe some benefit can occur. So these are